Okay, so we're down to kind of the last presenters before we have a working lunch. So Lori Flint from University of Chicago. Sorry, I know that. I know. I think works with the guy in the back there. I am losing it on my little sleep last night. But Lori's been really responsible for the journal clubs that we've been doing with the Nurse and Allied Health Network, which has been a challenge, getting people to find a time that works, and also I think getting people to volunteer. But we will talk a little bit more about the working groups during lunch, and then Janell Reichuber, correct? Reichuber. Yep, I said it right. From University of Kansas, is actually working on another project where they're developing kind of a new patient binder with all of the materials inside. So, yes. So we're going to try to break out into some of those groups during lunch and see if we can move some of those things forward. But they're going to kind of wrap everything up today, which I thought was a really creative. It's kind of the 4 T's. Is that right?
Now
6 T's?
Now 6.
6 T's.
So have
Okay.
talk.
Okay. So we may go a little bit late, but after this is done, we'll have lunch outside, and then we'll bring the lunch in, and we'll kind of break up into groups. So thanks.
All right. Hello, I'm Lori Flint.
And I'm Janell Reichuber.
So to get started, we're going to talk today about the 6 T's of successful ILD management, but after Janell talks about.
That's our objectives that we're going to hopefully cover. I don't need to read them all off. You can read them there for you.
So the 6 T's of successful ILD management, we can talk about team, talk, treat, trials, transplant, and transition. So this morning we talked about the ILDs, including the workup, treatment, and challenges that go along with them. But now hopefully we're going to pull it all together. When we initially began preparing for this talk, we discussed how there are 4 T's for ILD management: treatment, trial, transplant, and transition. However, when we communicated with each other on the phone, which we did
talked a lot.
Yes, we realized there's more that we are doing and can be doing, and that is talking and teaming up.
And the further we explored this, we realized that the team and the talk may actually be the biggest factors in the management of an ILD patient. It took us back for a moment when we thought of that, and we thought that's kind of really powerful how we can impact a patient's journey. The strength of our team and our communication, it helps the patient so much. So for like an example, if the patient's struggling to get a drug or is scared about their future, the communication and the support that you provide to that patient, that's what they're going to remember. So when we dive into this a little bit more, we want you to think about your own clinic experiences and things that you can add, take back, or change to help your patients in your clinic. And so far, we've received so many new ideas. I mean, I think we're all sitting there jotting down like things we're learning from different members of this group. So let's get started with our first T in the management, which is the team.
So the team. This is for all the college football fans in the room, and because I'm from the University of Michigan, I had to put this here. Now, your team may not always function the way it should. Case in point, our U of M football team this year, but you don't throw in the towel, right? You figure out what's wrong, you try to fix it, change it, and improve upon it. So why is the team approach best? So an article by Giovanna Ferrara, he notes international guidelines strongly recommend the multidisciplinary team approach in the diagnosis and treatment of IPF or pulmonary fibrosis. He also notes there's no clear recognition of who should be on this team, which is dependent on each center's resources. However, what is clear from multiple articles is the key role that the ILD specialty nurse plays in this team approach. The role of the ILD specialty nurse is one in which multiple hats need to be worn, and I think we've mentioned that a couple times. You're not only a nurse, you're a case manager, a social worker, a family interpreter, a mediator, counselor, cheerleader, and in some instances, a lawyer who gets to debate, appeal, and fight for your patient's rights. And we all know who that occurs with. So for this reason, the ILD specialty nurse needs to realize they cannot do it all. It's way too much and can cause burnout, which then doesn't help the patient, the team, or yourself. For this, we need to know who's on our team and have an understanding of who those members are and the roles. As we know, to be a part of the Care Center network, our basic requirements are a Care Center director, a nurse or equivalent, a radiologist, and pathologist. But your team may also consist of a medical assistant or whoever rooms your patient, a social worker to help with the patient needs, a clinical research coordinator to manage the clinical trial patients, and if you're lucky, an amazing administrator administrative assistant who helps with scheduling, paperwork, follow-up, and all the day-to-day things that make sure everything is going smoothly. Keep in mind that your team may be bigger or smaller depending on the size of your center, and you can always recruit based off your center's needs.
For example, and this is where the pharmacy person is who mentioned having on your team. Here we go. So at KU in Michigan, we actually met with our pharmacy teams, and they provided us with a dedicated pharmacy technician. So what this means for us is that they help us with obtaining the drug. They do our appeals a lot of times for us. They'll do our PAs. They'll work on free drug for our patients, and then even look at medication assistance for our patients. Our pharmacy at KU has 340B status and another special accreditation that allows the pharmacist, or allows our pharmacy to, one, house the specialty medication, so we are considered a specialty pharmacy. The pharmacist calls the patients, provides the education for us, documents it all in our EHR, which is awesome. And then also lets us know, they feed back to us and say, patient hasn't called for a prescription refilled, they're being, non-compliant, they're looking at our labs with us. We actually just got our own clinical pharmacist embedded in our clinic, which is awesome. And we truly appreciate the support of those team members, because then it allows us to look at other aspects of the patient's care. Another important member we've added to our team at KU is our film library. And I think sometimes they get overlooked, but they're an amazing team member for us. We got access to Nuance PowerShare, which is how we can send an electronic message to another center and say, hey, we need these films sent to us. I don't know about you guys, but I've spent hours on the phone trying to get to the radiology department, saying, I need this person's CT, and they're like, well, you don't have consent, or all of this other hoopla. And the film library there, they gave us the access. We can send the email or send the message. And then I emailed our film library specifically and said, requested images, let us know when they've arrived. So that I'm not sitting there clicking, finding where's the images here yet. They send us a message back saying they're uploaded, they're ready for viewing. There you go. The other thing they do for us is they'll send our images on a disc. We'll say, hey, we're going to send for transplant. Please gather all the images for us. And they automatically do it and send it. So that's not something that the nursing, the medical assistant is having to do. We're teaming up with them. Now that we've talked about most of our on-site team members, we're going to talk about off-site team members. And I hope you guys realize that we're a team right here. This group, we're an amazing team. We have this ability to send an email or get on the Mobilize app and say, hey, what's working at your center? Or what are you guys doing? Or hey, do you want to team up and do a research partnership together? This is amazing right here. And the other thing, though, is we wouldn't have this group without the PFF. They're also a huge member of this team. They kind of are the team. But we see over and over in our literature that patients want more education and resources. And I know, I think Kathy already plugged the PFF resource, but use that. There's so much information on there, and you don't have to reinvent that wheel. You can print patient med education right off of that. You don't have to make up your own. You can, but you just add a little more work to your day. But they have so much information, so I'd highly encourage you to get on there and look at all the education resources available.
Another external team member are pharmaceutical companies. They have nurse educators that can help with the drug education, as well as when we're trying to get the medication, let's try to use them to help us get the patient's medication. It's their medication, right? So they should be able to help us. Mm-hmm. And then, of course, we hate to admit it, but DME companies are also part of our team, right? We need them for our patients. Now, we know they cause us a bunch of headaches, but it's important to try to figure out and work with them, maybe even find some that can work with us. And if you do have someone like that, keep them on your list and keep, referring their patients to them. Mm-hmm. So the next slide is the many players that are part of our team. And these are all part of the ILD, network. And some of these, you may have some, you may not. Some of these team members we may work with frequently, some maybe only once, or on different parts along the patient's journey.
And I just kind of want to go wow for a moment because look how many people are on this list. This isn't probably even everyone either. So if you're thinking we forgot someone, you're probably right. But these patients are very complex and require a lot of individualized care. So there's going to be other specialties and players that need to be involved. And if you're sitting there thinking, well, crap, I don't have this person on my team and I want them on my team, go out and find them. Start a dialogue, within your center and get their contact information at another center, because you never know when you're going to need their help. Maybe they need an ILD presentation, or maybe with a lot of things in your center, you have to prove with documentation the need for them. We actually started making encounters on everything. Had our medical assistant make encounters, requesting images, requesting whatever. Just make that encounter, because when they pull that data, they see how many times you're going into contact with that patient, and then they're like, maybe they need some more support. So do what you can to get those members on your team. The bottom line, though, is that you will not know if you can get any of them or work with the team members you currently have without our next T for management, which is talking. Here's a great quote on talking, and the one we use at KU a lot is the squeaky wheel gets the grease, so you need to squeak a little bit more.
All right, so for the power of talk, who are you going to talk to? You're going to talk to everyone. You're going to talk to your patients, their caregivers, their families. You're going to talk to your internal, external teams, your families. But who else can you talk to? You can talk to the person at the checkout line. You can talk to your dentist, your congressman, your congresswoman, senators, because the more people that know about ILD, the more awareness you will bring. What should you talk about? Well, everything. You have ILD disease, symptoms, medications, oxygen devices, transplant program listing criteria, how the patient and family are doing, or what the patient or your center needs. And then when should you talk? Well, anytime. Anytime you have an opportunity to talk about this disease or what you do, then talk about it. However, we also remember that talking with patients about sensitive topics, to remember kind of the timing of these talks. Sometimes we cannot control the timing, but it's a thing to be aware of. For example, you don't want to call a patient at 4:25 on Friday with heavy news, because if you do that, our friend Dr. Google will come in over the weekend, and then the patient on Monday will be dissatisfied and have questions and be kind of a hot mess. So if the bad news does need to be communicated, perhaps bring them into clinic if you can. At least you know that's an option. But just make sure you're mindful of the timing of when you talk to these patients. Be attentive to their communication behavior, such as asking questions, communicating assertively, expressing concerns and feelings. If you are not getting any of that from your patient or family member, then you've lost them, and you need to go back, stop, and pick them back up again. And always remember, too, that the patient needs their time to talk.
We're going to go to the why here in a minute, but we're going to go ahead and go to the how first. There's so many ways to communicate. You can talk on the phone with them. You can talk in clinic with them. My chart, we have that. That's great. Social media, Twitter, Facebook, posters, presentations. The only thing to kind of really think about when you're talking is to know who your audience is and try to use their language. I think sometimes we forget that and we don't ask their preferred form of communication. I don't think that sometimes we try to break our terms down into simple use. We speak a lot of medical jargon, and when you're talking at them, I mean you can just see it go over their that blank stare, and you're like, okay, I completely lost them. So just talk with them and not at them. The why is talking so important? It's communication. It's how we connect to each other. It promotes awareness. It bridges knowledge gaps. It prevents errors and assumptions. We know what happens when we all assume something. And it's how you know what is working and what isn't working. It's how you take care of yourself. I think we all know the analogy of when you're on the plane and, they say if you have to put your oxygen, if the oxygen mask appears, put yours on first and then put it on the person beside you. We as nurses and allied health professionals, we need to take care of ourselves. We need to talk and decompress. We work with a lot of high acuity patients. We have a lot of system pressures within our healthcare that takes a lot of demands out of us. And then we lose a lot of patients. And that just really takes a toll on you as a person. So make sure you're talking to your team, your family, this group, whoever, because you have to take care of yourself too, and talking helps with that.
So these are two quotes from Tulsky and group who looked at communication between healthcare providers and patients regarding serious illnesses. What was shown is that there's an urgent need to improve the quality of communication in serious illnesses through more research that includes and covers communication skills, tools, patient education, and models of care. Another point that is made regarding communication with IPF and PF patients is that it can be greatly improved when the healthcare provider has a thorough understanding of the problems faced by the patient during their disease course. And that's why we're here today and at the summit. We need to learn and have more of a good understanding of not only the diseases, but what the patient's needs are, so we can better support our patients and give them what they want.
So what do they want? We know from our own experiences that it takes time for the patient to finally get to us. Whitus and group reported that 40% of patients have consulted 3 or more physicians, have undergone many tests, received conflicting information at various stages, and yet they're still left with so many questions. So what do they want? They want honesty, and more specifically, a balance of honesty and hope. They want information. As we've mentioned before, they want more resources, and we need to ask ourselves, what are we providing for them? Are we giving them binders, folders? Do we give them the PFF website? Lori told me a story that she saw on the PFF Warrior Facebook group page, which is an awesome site, that someone put on there, my husband was diagnosed with IPF in January, and what does she do now? It's a sad but true story. The other one they want to know is a prognosis. We know we can't predict their prognosis. We've seen those slides showing, this disease course. We can't do it. But what we can do is be honest and communicate with them about the course of this disease in empathetically worded, clear, and easy formats.
And self-management tools. Patients want to know or be able to take care of themselves. They want information about disease, nutrition, how to manage chest infections, and many of these can be accomplished through pulmonary rehab, which we have talked about quite a bit. And most patients view this as a positive intervention, enabling them to participate and manage their own disease and improve their quality of life. Consistency. We need to make sure we're all on the same team. DME and the pulmonary rehab are all communicating the same message so that they're not getting confusing or conflicting data. And then who do they call? Do your patients know who to call after they've been seen? Do they have your number? Were you able to meet them in person? Some I think are able, or were you able to call them out, call and introduce yourself after their appointment? Do they know what other team members they are available, and do they have those contact numbers? It's important for them to be able to get a hold of you, because obviously they're going to have, once a diagnosis is made and treatment starts, they're going to need some additional help and direction, and that brings us to our next T, which is our treatment.
Go ahead and list all of them out, will you?
Sure.
Because I think the important note to take away here is when a patient says, well, I'm not on any treatment, it's like, yeah, you are. You may not be on a medication, but you're getting treatment. And I don't think we always consider these as all treatment. We just, well, you're not on, drugs. So I think that's something to kind of take away from this. Most of us go to our MDD discussions, so we learn about the plan, and then we're able to call the patient and help with that plan and treatment process. Going back to the medication side of things, although it's not just about the drugs, the management of the medications can be huge. And so actually getting the drug, and then having the assistance from our pharmacy colleagues, that's so helpful. But the next challenge is the lab monitoring. And you had great points about how we can help with that.
And also, to ensure this, some of the things that we've done to help with patient safety and compliance is we have protocols in place for the medications and lab monitoring, which of course provides autonomy for us as nurses to assist with changes as needed. We also are working with our IT teams to get the lab monitoring built into our electronic medical records. And then of course we know symptom management is something that as nurses we can help with on the phone. We've talked about some of those here already. And then, of course, referrals to other specialties, such as, gastroenterology if they're having reflux, or weight loss management if they need to work on their BMI for transplant listing. And I am very big component about support groups. And it's important that if you run a support group, I commend you because I know it is a lot of work, but if you don't, do you know who does in the area? Is it a patient? Make sure you reach out to them. And of course, the PFF has a telephone support group, which I strongly encourage.
The other ones we really talked about in detail with the other speakers, so we're going to kind of skip over those details. With the DME, I would just make sure that the patient is fully aware of the process of it, because I think that sometimes is a huge, dissatisfier when they're like, I didn't realize it was going to take all this. So just make sure that they're aware of that process.
And now we have to figure out is treatment effective? And there's two ways the objective data, of course, we have our CT and PFTs, which can, if they have a treatment that medication will help with, will definitely show if there's improvement. But we know for many pulmonary fibrosis diagnosis, all those tests do is show the progression of the disease.
So when we were kind of researching our talk a little bit, I know with clinical trials they do a lot of PROMs, and we've kind of talked about that here as well, but would there be a chance that we can get these into our clinic setting? And I know the feasibility is the huge part, because they're like huge questionnaires and stuff. So I think that just really brings to light that we need to do more research on trying to make these more clinic accessible. And so then we know what happens if the patient tries and fails the medications and or wants to be part of a study or a trial. Then we have this option.
So with clinical trials, these are questions that are really important for you to be aware of, especially, do you have trials at your center? And then how are your patients notified, or how are your patients determined if they're part of the trial? Is it through your MDD? And who's a good candidate? And then if they're close to transplant eval, it's important to make sure that that information is related to the transplant team in case that affects that evaluation. And then who's going to follow the patient, which is very important, especially those that are on oxygen may need still a yearly clinic appointment for O2 certification. And then, of course, sometimes you don't have trials at your center. So these are two good resources to look for. The PFF has a pipeline, which is a fabulous resource, and I've sent it to all my patients in my support group. So it's a good place to look. And then, of course, the clinicaltrials.gov through the NIH.
So there are typically 3 phases of trials, phase 1, 2, and 3. That's kind of more of a better overview, but usually phase 1 is with healthy patients, and they're just seeing about the safety of it and safe dosage, side effects. The takeaway from this is going back to knowing your team members. You can use the PFF with their pipeline, but to defer a lot of your questions to your clinical nurse coordinators or your clinical research coordinators, because they're going to know the answers, or the physicians.
So our last couple of slides, I know we're out of time, so I apologize. Everybody's
We're
probably
hurrying.
hungry. So stem cell, patients will ask about stem cells. They do probably on a daily or weekly basis, because, and part of it, I think the for-profit stem cell centers are trying to recruit patients. So it's really important to make sure you know where to find the stem cell statement on the PFF website, which basically recommends that patients should only engage in cell-based therapies as part of an approved clinical trial in which they are closely monitored and potential benefits and harm can be objectively assessed. And then the right to try came into effect on May 30th, 2018. It's just another way for patients to try to get medications that have life-threatening diseases who have failed all approved options. But there's a lot that's involved to go through this, and ultimately the drug company and sponsor can say yes or no.
So transplant, Rebecca already talked about this, so we're not going to go into much detail. Just here's a list of questions that you may want to know and be able to answer. We don't currently have a transplant center at KU. We do a lot of work with our Barnes-Jewish in St. Louis. We refer there a lot, and they actually let us take the patients back earlier, and then we manage them here in Kansas City, and then we send all the information to Barnes. Our systems talk to each other. They trust us. We built that relationship with them, and that'd be an option if you don't have a transplant center. We know now if patients aren't transplant candidates, we're going to roll into our last T, which is transition. It doesn't mean the last option. As we've heard from Kathy multiple times, it needs to be talked about early, often, and ongoing.
Correct. So these are also some important questions to know the answers to with regards to palliative care within your center. Of course, you know, we then talking about PROMs or needs assessment guide, which is important to kind of figure out what's going on with the patients and family, but obviously we know there's much work to do to get those into our clinics. And our last
So,
one.
with that being said, we hopefully have left you with some thoughts or ideas to take back to your centers. Maybe some process improvements like adding protocols or starting conversations so you can start building your team. And for your patients, we hope that we provided more information for you to increase your knowledge or provide new strategies for communication. Maybe even look at more assessment tools for your clinic. And for this group, what can we do? Well, as a group, we continue working together to make changes nationally and locally. And to think back just a couple years ago, we sat together in a room in Nashville at 3 dinner tables, and now we have this huge nursing and allied health network. So let's keep talking, getting involved, sharing ideas, teaming up, because I don't know about y'all. I'm really excited to see what the next 2 years are going to bring.